This is my topic. And for those who are junior or very young in the career, I know medicine is a business. So I have to select between economics and business. What should be the better title? So I selected economics for a reason which I will tell you in a minute. And again, some disclosure, I have nothing to wear it. I don't work for an industry. I don't have any financial affiliations. So basically, these are my objectives. And again, because I'm going to reiterate it again, I just want to save time for the real meet. So I'm going to just skip that. So basically, what's the difference between economics and business? So business is just a transaction between two people, and we do that daily in medicine. But I'm going to focus on the economics part, where how your career, your decision making, and everything really changes the whole parameter for you, for patients, and for the community. So you will see the difference in couple slides. So just an example, like this is from an yeah. So look at pediatric nephrology. Can you guys see which states have zero pediatric nephrology? I know we are not geography. Any guesses? There are two states with no pediatric nephrology representation: Montana and Wyoming. And understandably, because like people treat these states as little remote areas, but I said maybe they have less kids. That's why there is no PDA. But I compared it and imagine Montana has 23%, Wyoming has 21%, and Louisiana has 25%. So it's not that they don't have kids. That's why people don't want to move there. And why pediatric nephrologists? We all know that we are running short of pediatric nephrologists for a reason. So there is some economic reason to that, and there are other reasons which have touch base. So let's compare this only with pediatric nephrology or with pediatric cardiology. So you see pediatric cardiology at least, but we don't have anyone in Wyoming. But see the numbers are changing. Then we compare it with pediatric pulmonology, but look at neonatology. And my specialty in neonatology, and look at like in bigger states, 9.2 average per 100,000. So again, the point which I want to make that whatever decision you make in your life, in your career, it really impacts the representation in the community. This is the busy slide, so I have made it easy for you. Suppose, let's take an example of a 16-year-old. Oh, what happened? Okay, yeah. What happened to my presentation?
You're saying income.
AG. I can see it there at the sides. Ah, okay, good. Let's see. Okay, so 16, 17-year-old with cold or URI. So one option is that the patient will say that I will self-care myself, no burden on me, no burden on anybody. The economics will remain okay, the business remains okay. I'll just take some Tylenol and I'm good. The other option is he said, no, I have to go to PCP. It's getting a little worse. And then he said, no, I might have to see the ER. And these all will have impact on the business, the cost, the care. So then what happened? Poor guy developed pneumonia. So now he doesn't have much option. Really, he have two options to of either outpatient care or inpatient care. But again, this will have impact on again the business cycle. Unfortunately, this pneumonia ends up with empyema. So now you know that there's no more in outpatient deal. It has to be inpatient deal. So now this is inpatient. So all this boils down to two things: bills, which the patient have to pay, and the payment with patient, and what the physicians or the providers has to do with all these type of problems. And we're going to touch base on a little business side. So there are two sides. Of course, one is the patient side and one is the provider side. Uh, you are in, but people like me, we see patient side a lot because we have to have different subspecialty taking care of our cholesterol and this and that. And we really look at our bills and it's cumbersome. It's not easy, honestly. So I'm not going to touch on the patient side. My talk will be on the provider side. So students, intern, residents, whoever can benefit from this. So this is our talk going to be. So two terminologies which you have to understand. One is the CPT and one is the DRG. Just bear with me. I'll try to make it easy on you. So going back to the same example of URI, if the patient sees a PCP and PCP said, okay, this is URI has a code and this code has a billing attached to it. So that is easy. Outpatient is easy. CPT, you don't deal with diagnosis related until it's a complicated case. But same case when it becomes empyema, then you have to have a CPT of empyema. Plus, now there's so many complications. You have to select pneumonia with complications, empyema with this, maybe an organism there. So the more complicated case you have, your billing increases. Is this the right thing to do? I don't know, but this is the thing which we follow. That's why we're doing this done. So again, I told you already about that, but just have to put a slide. You will have access to the video, presentation. And DRG, this I just want to stay here for example, an orthopedic surgeon doing a knee transplant or knee exchange, whatever you want to say. So that will be a different DRG than taking care of implant. So the more resources of simple is the more resources are used, the higher is the billing tier. So just remember that. And again, we are going to talk about it. So now again, going back to this example. So see, one is CPT, the other one is DRG. So you have to just understand the whole dynamics that will help you in choosing your career path. I hope they start paying good to PCPs. We need good PCPs, but unfortunately, because of the payment scale, most of the people go to subspecialty. And I can't say that because I'm also in subspecialty. But anyway, so now the question is, like we said, we are going to talk about the provider side. Like, we all have to know we spend so much in our schools and our, so much of loan on us is going to pay off at the end of the day, like what specialty I choose, which is more lucrative. So that is very important. So my income depends upon the number of patients I see and bill daily. Do you guys think it's a yes or no? Any idea? We just touched base that it depends upon the DRG. So, or a case mix. So if you see a very complicated case, one that has a higher bill tier as compared to simple cases. So that's why the PCPs unfortunately are not paid well. Although if you see from the public health perspective, they are doing a better job, honestly, making sure that a URI does not become in time. Actually, I was surprised that I got $35 from my insurance company back for going for my PCP annual visit. So they are paying me $35 for being a good patient following, with the PCP. And it's a very good strategy. Basically, you want to save straightforward. So true or false, we talked about it. So because I'm an neonatologist, I'm going to give you some example from nursery, but you can apply to honestly just like we did with URI. So, and I'll walk you through. So you don't have to be a neonatologist. This is a slide I borrowed from a guy, who presented it, and I loved it that big baby, small dollars, small babies, big dollars. Like now we are resuscitating 22 and 5 babies. Don't ask me if we are doing it right or wrong. But one thing I want to say is that it's a service which we provide, but it comes with a cost. Cost to the family, cost to the community, cost ultimately, our tax money is going there. So we have to question really, should we do it, how we do it, and how we can make it easier on both parties, for the patients and for the provider. So okay, so it's not about the numbers. Acuity counts. And now you guys getting an idea. That's why some people want to do pediatric GI. They want more procedure. A quick tip for students: if you want to earn more, choose a specialty with procedures. Okay, because procedures pay. Less procedures you opt for, less you're going to pay. So anyway, there are 4 quadrants I'm going to talk about and try to make it easy on you that what really at the end of the day bring monies to you or to the hospital or to your employer. And I will tell you a little trick how to negotiate your contract when you graduate and what are the numbers and how you do that. It's very important. Unfortunately, we are so naive. Whatever comes our first way, and we have so many loans, we just sign it. We just look at the legal part of his 60-day notice, 90-day this, and we are good. But no, look at your numbers, what they're offering you. And there's a formula to it, which I will tell you. Okay, so these are the 4 things. So now we know that numbers, of course, matters. Your coding does matter. If you see a URI, pneumonia, or empyema, and definitely the more complicated cases, that you have more DRGs, and of course, the staffing. So if you have everything under control, but your staff, you have hired like 60 people to take care of it, then of course your cost divided by staffing, simple math. So that's why in certain primary practice, it's so frustrating that the same person who will check you in goes back and take your vitals. And you said, are you a nurse? No, I'm not a nurse, but today we have shortage, so I'm doing the nursing job. So you started to feel, God, why they are cutting costs there? But it's not about cost. Sometimes it's the staffing that really makes a big difference. And I'm going to talk about that how it changes the whole paradigm of what patient feels, and we all are evaluated on patient satisfaction score, which is really very cruel. Like if they don't get a parking outside, what it has to do with my practice? I'm a good physician. I try to take, but they're so dissatisfied that whatever I do from onward is not going to count anymore. But there are ways we can rectify. As long as we understand the business side of it, then we can at least not go to Washington, D.C., but we at least put our voice. Okay. So now revenues. This is very important. They don't teach you in medical. I don't know if they teach you now, but I was not taught what is revenue, like how my care is translated into money. I don't know this transition. And they make it so complicated, this number, that you said, okay, fine, just give me the salary and I'm happy with it. But trust me, it's not that difficult if you understand. So let's just start. So the word they use is relative value unit, RVUs. You might have heard of it, but this RVUs is going to decide your salary. So for example, suppose you have finished your medical school, you have finished your residency, and you got a first contract, and they are paying you, they said, we'll pay you 260K with production model. And you don't know what production model is. So you sign it. After 2 years, they said, we are going to cut it back to 220 because you did not generated the amount which we agreed. But you said you never mentioned that. And you see in the fine prints, just like your marriage contract, at the end, if you are wrong, then you'll lose the house. So something like that. So anyway, so let's go and dissect it further to see how it works. So I talked about it. This is again a conversion, just like DRGs. They have like, the CMS really sits on it and they have a formula to it. But for us, it's important to know how from CPT we get to money, like this transition. So again, so for example, I have like these are the patient I coded. So CPT code 1990, and this is, I tell you, like a feeder and grower, a baby with ventilation. So there is a code to it, which you can get it on Epic, so it's no rocket science. So coming with the code is not a problem. Now I have seen 25 patients with the first code, and then I have seen different distribution. Then so you multiply that. So I have generated 163 work RVUs, and my total work RVUs are that. So it's simple mathematics. But now I have to know how can I convert these RVUs from CPT. You are with me now that I know there is an RVU attached to it. How many I see I generate this. So this RVU has some dollars to it. So how can I get to the dollars? So the dollar is, this is the thing that every year the CMS and CMS, that is Center for Medicare, they decide what is the conversion factor. So for 2023 it was 33, and now, so they keep on changing. So roughly take it as a 30. So whatever your RVU is, you multiply by 30. So on a daily basis, if you see 20 patients, you have an RVU, you can actually gauge your salary. So going back to the example of this 260 salary and they cut it back to 220, the reason is you didn't know your practice. So suppose you are seeing, you're interviewing, and you say, okay, what about what's your every daily census? And they said, oh, we run from 10 to 15. And what type of patient do you see? Oh, we see all the nursery babies, but we don't keep any baby less than 32 weeks. So right away, you know that I'm not going to generate that much. So basically, they just want you to sign in, and then gradually they will penalize on that. So what you do then, you change from production model. You said, I want a blanket salary. But suppose other way around, you are a rheumatologist and you go there and you see a big potential. You are practicing in Kentucky with all these, boldness, and if people get that. You said, sure, I will go on production model after 2 years because you can project and you can see your RVUs coming in. So you're getting my point. That it's not only knowing about taking care of patients, it's taking care of yourself as well. You have worked so hard. So please don't let it go. You don't have to hire an MBA or a lawyer to look at your contract, honestly. So easy as long as you know the math and you know what question to ask your recruiter or your HR. So anyway, so now you know how the conversion happens. So again, income is really complicated, but if you understand, so now let me give an example of physician or a provider. The total generated, let me make it little large. So the total generated RVUs were 11,601. So then what they do to control further, they give you a target. But again, this is not they. Your employer has obligations. They cannot give a random target that, oh, you are a pediatric gastroenterologist or you're a rheumatologist or a cardiologist. You have to generate that. There is a standard MGMA standard where they have to follow. Suppose they give you this number, and in this case, this gal is lucky because he or she generated more than the target. So all good to go. So now they can, so this is, like I said, 65th percentile. So again, when you negotiate, you say, what is my RVU target? And they say 10,000. So you ask based on what? Based on just a number from the hat of a magician? No, it's a number based on what nationally your specialty physicians or providers generate. So it's so easy, honestly, as long as you understand. It took me a while to understand that, and I regret if I would known when I was younger, I would have saved a lot of money and made a lot of money, but I didn't know that. So anyway, so coming back to the same slide, the four quadrant. So we'll just walk you through, and honestly, now you guys have an idea that how these four quadrants really work in income generation. So I hope you guys have an inflation in the income, not at the cost of living. So now again, going back to this, so some examples. So again, when you're negotiating your contract, you have to look at your average daily census I talk about. The other important component is length of stay. So there is a catch between length of stay and your daily census. So a person you have, suppose your partner is very conservative. He said, no, he want to see the baby's jaundice back down to 3 before he discharge. And you're very aggressive. You said, you know what, 10 is fine. Patient could be followed as an outpatient. So what happened? He generates more because he keeps the babies longer or the patient longer, but at the cost of length of stay. So how nicely they have put length of stay that for the same condition, if I'm keeping the baby longer and generating more, that's not nice. That's not good. I should be penalized actually for that. I should be said, no, you have to. So again, they have guidelines for that. So you cannot just bill the patients. When I was younger, I did something wrong. I regret it. I worked for somebody in Texas and he was keeping babies on 2-liter cannula unnecessarily because I didn't know I was covering for a week, because you can bill on a higher tier if you keep the babies on nasal cannula of 2-liter and more. And most of the babies honestly don't need it. But you're locum, you need money and you don't want to. Anyway, so if you have time and if you want to play your card right, trust me, negotiate it. You can do it. And you don't have to practice wrong, honestly, because somebody can easily make out. If I'm an investigator, I said, how come your 34-weeker who is feeding well is on nasal cannula? Doesn't make any sense. So it's not only the system, sometimes it's the greed of a person too. But so balance it and work for it. So just an example, see how, again, NICU, and I'm just going to, just go fast with these slides just to see that the cost goes up, in years it's going up, you can make it out. So of course, so see, like, it's easy to make out. The higher the level of care, the cost is. So that's why when you negotiate to be a neonatologist, people go for level 3 PE or level 4. Level 2 is good lifestyle, but again, you gauge your income with your lifestyle. And again, another example that the cost of care, of course, going back to LOS, length of stay. The longer the stay, you will make more. But again, you have to be very careful. Now there are so many quality indicators, which I'm going to touch later on, that they are being watched. Like you are being watched by people, that how come you will get a note that this patient stayed longer than the expected discharge date. Please explain. And then, and not only that, you will have denial from insurance. So it's good that you should know your art, honestly. Unfortunately, medicine has gone from just writing prescriptions to really managing your finances. So it's very important that you have to know the game. Otherwise, trust me, you will not be doing any touchdowns anymore. Okay, the two examples from community level 2 hospitals. And again, I'm just going to go fast. Just see on the right side here, see how the income, like the expenses and the balance is in negative as compared to a level 3 big unit, you are in surplus. But again, you have to understand, if you're opening your own practice these days, unfortunately, because of corporate culture and EMR and so much of overheads, it's very difficult to survive alone in any community. You have to buy into some group, unfortunately. The reason is this, because your cost of, maintaining the practice goes up. You have to hire, staff and all that. My own internist in last 6 years, he has gone from his own private practice. Now he has joined a corporate. And he seems more happy than before, because now he doesn't have to take care of the lab person who is not skilled enough to draw the blood. The patient complains to this physician, how come your lab is not good? So now he just comes, take a lump sum salary, I don't know, he's on RVUs or what, and be happy with it. The system takes care of his expenses. So this is an example, although I use the NICU example, but just to tell you, you increase that, but again, the larger the sphere, your complications get more. So something like that. But if you know how to manage that, it's always good to earn more. Like people say, if you go cross 350 salary, you'll be paying more taxes. Your bracket will go to 35%. That's fine. Rather than working at 80% and paying 10% taxes. I'm still making good money, living a good life. So don't be shy from making money. Please commit to yourself. We are here for money. Yes, say it loud. Is human service? Definitely. We are there, but we are for money. Okay, so now we are going to talk about a little bit about just to give an example, especially pertaining to nursery, the problem which face in nursery is that baby is born, baby does not have a name attached to the baby. Like we have a baby recently, the baby needed Levanox, which is heparin to go, and now the baby is not even registered. Baby does not even have her own Medicaid yet. So now the mom has to be that child. And for you also, see provider patient's problem, and the provider problem is you don't know who to bill. So that bill will. So you're seeing someone, you're providing a service, and it not in cash. So one is that. The second thing is remember we talk about uh, remember like this, when you're doing a private practice, everything is yours. When you are working for a corporate, then you have to negotiate how you'll be paid. Would I be paid for my CPT codes, like what I generate RVUs, or should I be paid for DRGs and a bigger model or whatever? So just understand those things. See how everything changes because the fee structure is different for different disciplines. Again, same thing, talk about again. So you increase income by all that, but see staff, which we talked about. And again, I'm just going to go through that although people think that NICU people make great money, but look at the birth rates. We expected the COVID to bring a lot of, babies, but it never happened. I think people opted to watch Netflix rather than make babies. So anyway, so we don't have that surge we were expecting. And you guys can see that NICU is only 1 to 2% of the whole cost, which we give it to our healthcare. So now, again, I'm just using this analogy and example, and you can apply to any practice, rheumatology, pediatric pulmonology. Like suppose pediatric pulmonology, they offer you a contract and you have a CF clinic, you have an asthma clinic, you have so many clinics running, and they're still paying you the same which they pay any pulmonologist. You not negotiate there. You said, no, come on, you have so many obligations. So in NICU, we have level 1, level 2, level 3, and by now you know that more the level of care, the more earning you have. Again, like I said, I'm just going to skip through that. This slide, I just want to focus on that. What this guy did, he said, I want more level 3 because I can earn more. But what happened? Then you have to provide staffing. Like for NICU, real example, especially in Texas, there are a lot of level 3 popping up in a smaller area. The reason is level 3 billing, you can make more money. But they don't realize to keep a level 3, you have to have an in-house NNP or a physician. So now your work model changes. You have to hire more NNP. If they come to me, they said you have to sleep in house, I will ask for more money rather than if I go home and I take a call from. So whole dynamic changes with change in the model of practice. So people say, why not to use AI? So this is what the old people used to do. This is the scribe real example. See how they used to scribe and they get all the pains and all the problems. And now we haven't changed much, honestly. We still do scribe in a same way. So anyway, so I don't know you guys have known this, but this is very interesting that they found a new thing in the brain. The ARI found, I think, right basal ganglia or something. So not everything AI does is right. Okay, so you have to use your gadgets and resources here. Now I will switch gear. Like I said that now we have learned that billing is important, care is important, but quality is very important too. Whenever you are like, for example, when Apple came and BlackBerry was just drowning, the thing which Steve Jobs sell was the quality. And really that is, even if in the packing of iPhone, it's very sleek. It comes, you open it, you get a feel of it. So it is the quality. Plus, of course, you have to trust your product. So if you're a good physician, you have to trust your skill, but you have to market yourself and believe and portray and say that what quality I'm giving, you're not going to get across this. And you have to believe it. So we're going to talk about it that, of course, with increased quality, you have to staffing, there are other things attached to it. So again, going back to the title of the topic, the economics of medicine or cost or business is not only on the practice side. Quality should be inculcated or should be put in the overall value of my care. And that's why you see the equation that value is quality on the numerator. So if I provide an excellent care, Even if I see less number, I should be, rewarded for that. And that model is coming gradually, but it takes time to bring some change. So I said, let's search and see, do we have some talks on quality in healthcare? And look at this. This is one screenshot, and trust me, it's if you scroll down. So people have done so much on quality healthcare and all that. There's so many PowerPoint presentation already available. And so people are thinking. It's not recently. For last 20 years or more than, people are talking about quality care.
For them, please help me get it. And then I'll add the blood culture for brother.
Mute yourself.
So think outside the shell. So, okay, so you have to think something to bring quality, honestly. Like especially in electronic world, I see how these engineers, they come out with design thinking, and they make sleek things. Like there was time when ketchup, you have to put this way, now the ketchup comes standing down. Somebody thought of it. All the face washes and all that comes with a flat, and you can put toothpaste, like they have collapsible. So somebody thought of it. Old days, you have to keep on pressing. And so you have to, like, same thing in medicine, or think of some innovation. How can we provide the same care cheaper and better? Like, we don't want to compromise on the quality, but think of it. The only problem is when we are talking about the care, it's not gauged, so you're not paid as compared to the equipment. If you make a good flask or something, people like it, you are paid, you see the money coming in. With quality in patient care, unfortunately, it's your satisfaction end of the day, or your employer giving you a medal at the end of the year, say that, oh, you know what, we recognizes you, you did a phenomenal job, you got a lot of A's from your patients. So now let's see, remember I talked to you about that, what are the quality metrics? You will be judged, and you have to know the art. Like, oh, they are going to judge me on that. So let's take one example, mortality. We all know that higher the mortality in your practice will be looked very critical. So what is that? Second is length of stay. Remember the equation, length of stay plus, your daily census, you have to balance it. Don't keep babies, like I gave you the example, putting on nasal cannula or just not discharging, making a reason like, oh, I need IV antibiotics for 3 more days. Why? You have given like 4 days of parenteral antibiotics, a benign kind of thing. They drain your abscess. The rest of the 3 days you can do it as an outpatient. It's good on you. It's good on community. It's good on my practice. So why should I keep the baby just to make it or child, whatever, to make money? Readmits. Again, remember your length of stay is attached with readmits. So at one side, you don't want to keep them longer, but at the other side, you don't want to discharge them quicker. Because if you discharge them quicker and they get readmitted within 30 days, you are dead. You are not a good physician. They said, oh, how come in last 2 months, your 5 patients came back? And we reviewed it, you discharged that one, the sickle cell crisis earlier, that one. So you just have to balance. So you have to know your art or your game. Otherwise, trust me, you will be falling apart. Then you have to catch these near misses early. And then of course, cost we talked about. And this is again, like, like I said, you are being surveyed. Even now, if we order anything, we look for a star on Amazon, and we see anything less than 4 stars, we don't even order. You don't even go. If 4.5, you see how many? Only 2 reviews. So you don't want to go there too. So look at how many people reviewed it. But the problem with the survey is if 2 patients are dissatisfied with you and 100 are satisfied, they will go with 2, which is really cruel. You should take an average and see my performance. And like I said, there are many ways, one is Prisgani, these are companies, how this corporate is like building up around you. And like, see, for example, the first one, cleanliness of the facility. I'm just a physician. I come and I work, I want to perform, really nice. If this is not vacuumed, I should not be penalized for that. But that's how the facilities are. And honestly, it's a good thing to have. Otherwise, what will happen? Then things will fall apart. But your practice should not be gauged on the parameters which you have no control on. Something like that. Like if somebody came in my dream, my wife should not penalize me for that. I have no control on that. If I go out and have a child dining with her, then of course you can penalize me for that. Don't use that analogy. Okay, so there are certain questions, like I was telling you that. Then you have to, as a customer, I don't know if you guys have done that, but like I said, as a customer, you have to evaluate a practice. If you go to a practice, you're satisfied, not satisfied, there are certain numbers. And then they score it. So this is how the scorecard comes. So again, like I said, look at the quality metrics they evaluate you for. So now they have gone from Prisgani to Alteryx is just change of the name. Basically, same thing. What I'm coming to with all these slides are that you are just not a physician. Your practice is being monitored by many people to see if you're providing the care up to the par. Again, the same thing, this is a very nice example. Look how in 1988, the first place got for 9.9 seconds. And now same thing, and he got the last. So you guys are so unlucky. We did great because our targets were, if I can run 200 meters in 9.9 seconds, I will get the first prize. You will get last prize. So I cannot have extra legs or wide legs. So why you are, so this is the reality that the quality metrics keep on changing with time. So you guys have entered a world which is really not that easy when I was a resident or a student. So what was excellent yesterday might not be enough today. So know your business, know your field of a specialty, what you're dealing with. So and these are certain examples that it is so sad to see that encyclopedia they have made a room out of it, and all goes to Google and AI. No, I don't think so that anybody owns the this encyclopedia Britannica. I know a friend used to have like 13 or 14, you know, the shelf there. And I said, nice, have you read it? He said, no, I got it. I matched with my curtains. So that's why I got it. So poor guy was also that smart. I thought that he got it because he wanted to learn, but he just matched with his curtain. So, and you know how the iPhone has evolved. So I use the example of this electronics. Trust me, your practice should evolve with time too. Otherwise, if you are the same what you were 10 years ago, you're not really improving. There's something you have to bring to your practice. I know it's very difficult in patient care to bring innovation, but again, think simply that how can even talking to family can make a difference? And sometimes it does, honestly, like spending 5 minutes extra, probably that we're not expecting, and you are there and you say, oh yeah, I see a very satisfied patient there. But again, if you have to see 30 patients in primary care, how can I like really expect you to talk to the family for 15 minutes? And guess what? When you bill, your CPT code is 20 minutes average time, and you spend only 6 minutes with that patient. I tell you, my PCP is so busy. Actually, now you cannot even get a new patient to his practice. So he spends not even more than 6 minutes with annual visits. So he just asked me a question, your blood pressure, okay, take that. And he said, take a deep breath here, take a deep breath here, all done. That's it. That's my exam. Not even ear, nose, and throat. Okay. So, and that's what, if he starts spending 15 minutes talking to me about what I'm going through in my life, he will end up seeing 6 patients and then his practice will be taken. So what we are asking is easy on an iPhone that they can bring a camera, extra camera there or extra button will be satisfied, but it's very difficult to satisfy a patient. So you have to see from that perspective as well. And you guys know already about this iPhone. So now let's talk about that. I talked about business, I talk about all that, and we want to change now. So we all agree that change is difficult. So now let's bring changes in our life. Like how can we become a better person or we practice better than before? So there's a book which, if you guys can read, that's a nice book. So basically, but I will give you the gist of it. So if you don't have time, you get it. So basically, it's just like you see it's a J-shaped curve. We'll talk about it. So this is how the change, and you guys know it honestly. See how these writers take a normal human behavior phenomena, develop like a mathematical equation to that, and publish a book, and they're bestsellers. I don't know if this book is bestseller or not. But anyway, see how when you start a change, there'll be anger, resistance. People will say, no, we haven't done it before. And like changing antibiotics in NICU, it's really it's very difficult to talk to people because they go with all these fear, anger. They said they have done it for so long, or any other example. If you try to bring a change in practice, it's not easy. People will not say, "Oh, come, please, you're more." You have to go through this initial part. Really, it's like a steep thing. So in stage two, you try to probably you're moving now. That some people, one or two people say it's not a bad idea, really. I think we don't have to treat everybody with phototherapy just to be sure. Just order a CVC. What routine labs? What do you mean routine labs? A bronchiolitis 3-month-old start nebulization, put on SAT monitor. No, we don't have to do that. Somebody thought of it. A 6-year-old fall in the class, come here, CT scan, MRI, ultra. Why you're doing all that? First of all, there's no need. Exam is normal. So somebody has to think, bring that change. And then of course, see how the J is moving now, that people start, now you're in a valley. And then of course you started to see that, and then you reach the market. It took me 2 minutes to do that. So easy on the slides, but trust me, life is very difficult. Just especially the first change, first stage, first two stages are very difficult. Bring any change, talking to people because we all have these anchoring biases with us where we train, we say, oh, we have done this all our life. What do you mean? Like, for example, uh, getting echoes on all babies with murmurs in newborns. If the risk factor is fine, but if we have availability, doesn't mean that you should do. So there's cost attached to it. So once you attach a cost, it's really a something, uh, understandably difficult. I give you an example. I was attending a conference in a state that is very, very conservative. And I was naive, new, I didn't know. So they presented that time they were not resuscitating 23 and below. So I raised my hand and I asked the presenter that you are saying that we should resuscitate. And I came from a very poor, country where we have to really select, should we put a ventilator on a 32-weeker or a baby with HIE? Have to really select. It's so sad anyway. So he said, what's your question? I said, if parents have to pay out of their pocket, do they still offer full care for 23 weekend? So he said, I have a very good question. I'll talk to you later. I said, okay, fine. Then during the break, an old guy came to me. He said, look, young boy, you asked a very good question, but in a very wrong forum. So the point you want to make is that sometime because people are not ready for that or that question. So and I didn't know the dynamics of how the finances work in NICU. So knowing it, trust me, now if you see anything, you say, you know what, I have a talk the other day in pediatric department, and I know it's not difficult to understand these dynamics. And let's be part of the community rather than working in silo as a practitioner and just go work. People run marathon to bring money and for causes. So do some marathon there. Okay, and see if you have seen taken, you know that I will find you and teach you the economics of the medicine. So I can do that. So healthcare, economics, otherwise I'll ask Ian Nelson to do it for me. So now again, going back, I'm going to just close my talk. So work as a team. This is very important. Like I said, you cannot work in silo in healthcare. Healthcare is a responsibility of the whole community. It's not that I just go to work, I do my part, I write my note, or as an attending, I co-sign it, and I'm done. Like other day, people have seen that I was talking to a family, even making sure they have supplies of Livernox at home. Who will do that? Asking pharmacy to teach them. It is our responsibility. Think from whenever you're in trouble, or think from the patient's perspective. If it's your child, and some people are not that knowledgeable, honestly, that you should not assume that they know everything about care. Like I'll give my example. When my kids were young and I used to go for their vaccination and record, my wife used to remove my card. She said, they will not tell me what to follow. They will assume that you know everything. So trust me, I have to take my card off and like this one standing there. And not only that, my daughter got sick. She had some infection and they tried like 3 times to get the culture and they cannot get. So I finally have to stood up and I said, can I just try? So who are you? Then I bring my card. I said, I'm a fellow here. Okay, only one try. And I got it. So I was like, so it's not easy, honestly. And I think she was not wrong because she's not a physician. She just want to know the real care for my baby. So just make sure you walk that extra mile for your family. So work as a team. Then of course, we talked about already that how change is difficult, but how come we are so fast with adopting a new electronic thing rather than adopting a new practice? Like I know you guys are young enough, but when I took my first driving test, somebody told me that always show your instructor that you're looking in the rear mirror, that you know how to. So you before you even pull out your car, you sit there, you see at the back, and now you have a camera, so you don't have to do that. So that practice has shaded away of you don't need that because the moment you put the reverse, you will have a camera right away. You'll see where you are going. Then of course, know your business. This is a very important insert which I put it. Please know your business. You don't have to be an MBA or a business tycoon or the understanding of all the business pages on the newspaper. You just have to know how my practice converts to CPT, converts to DRG, converts to revenues, units, and converts to my salary. How can my practice numbers dictate my salary? How I'm going to bring a change to the community? How can I provide a better quality care to my patient? If you know all that, you will be very satisfied, I hope, if the corporate lets you do that. And of course, this Venn diagram is very important. You cannot cut one bit without the other. So if you decrease the cost, but your quality goes down and you are making more money, But again, your quality is down, so you just have to, this is your own conscience. So I want to thank, these resources which I talked about. And this is something about me and the month's slide, which is